Welcome, everybody. We're just going to let people populate in. So as you're coming in, um, we'll just be sitting here for a minute. But thank you so much for joining us. I'm watching the participant numbers tick up. So, people are joining, which is great. Welcome, everyone. For people just joining, we're just letting people log in. So we're going to give that about another minute before we get started. Okay, I think I will kick us off. Thank you so much, everyone, for hopping on our webinar. My name is Jordan Goldberg, and I'm the Director of Policy at the Primary Care Development Corporation. And I'm really thrilled to welcome all of our panelists today and all of our attendees to our webinar. PCDC has been incredibly fortunate over the last year to have had the opportunity to work closely with the Commonwealth Fund and the Milbank Memorial Fund to launch and manage a network of stakeholders who are focused on increasing resources to primary care. I'm so excited to introduce our panel today, which is of leaders who are working across the country, who are trying to make a difference on primary care and hope to reorient our system towards primary care. And so we're going to hear from 4 different panelists and then have a moderated discussion. Hopefully we'll have a little bit of time to answer some questions from the attendees. So I encourage you to put any questions you have in the Q&A function. Someone will be moderating, watching that for questions coming in, and during the panel discussion, at the end, we'll have a chance to answer some of those. And so let me just introduce our panelists to you. We have Dr. Lisa Delsky-Watkins, who is the Director of Primary Care Networks from the Milbank Memorial Fund. We have Betsy Boyd-Flynn, who's the Executive Director of the Oregon Academy of Family Physicians. Hanna Nagy, who's the Lead Planning Analyst with the Connecticut Office of Health Strategy. And Louise Cohen, the CEO of the Primary Care Development Corporation. So my boss's boss. And we're very fortunate to be joined by Corinne Lewis from the Commonwealth Fund, who's going to moderate our panel. All of our panelists have extensive and illustrious backgrounds, so I'm not going to be able to go through all of those today if we want to have a chance to actually hear from them. But Jennifer Lyons from PCDC is going to put those in the chat, and you can learn more about them from all of their different websites, I'm sure. So with that, I'm going to turn it over to Corinne. Oh, sorry, I'm going to turn it over to Lisa to give us the overview of how things are going on primary care at the state and federal level, and we'll take it from there. Thank you.
Thanks very much, Jordan. I really appreciate this opportunity to share what we have been doing for the last year or so, and actually for pretty much everyone who is on this Zoom right now. This work has been ongoing for many, many years, and in earnest, certainly over the last decade. So I wanted to just start with this particular study that was published in 2021. This is implementing high quality primary care, rebuilding the foundation of healthcare. And it really has garnered a lot of attention, appropriately so, as a national call to action to support primary care. And much of the work that we'll be hearing about today really builds on a lot of the basic principles that were outlined in this. But essentially, the statement that you hear over and over again is that high quality primary care is at the very foundation of a high quality health system. And we are all joined in unity to support increasing innovations for the way primary care is delivered, for the way it is paid for, and frankly, for the total amount that is invested in primary care. Next slide, please. There's been activity at the national level that I'd like to talk about a little bit. There was talk of a primary care action plan coming from HHS, which has not yet emerged, but there was, in response to a lot of the work that had been done over the last few years to pull that information together, an issue brief that was released last November. This really was a very extensive list of activities that the federal government has supported or taken independently. And it's a helpful outline to get some sense of the action at the national level. What we're going to be talking about today is the work at the state level, but I want to put the context out there that there is certainly a great desire and certainly laudable efforts on the national scene to move primary care more into the spotlight, and frankly with more fair compensation and support for primary care practices. Next slide, please. So CMI did respond to a lot of the information that's been that they have in the issue brief, and there have been the creation and release and announcement of several new primary care models from the Innovation Center at CMS. The first one on your left, making care primary, all of these were announced within the last 6 months. There's also many models that we've had experience with over the last 10 to 15 years that have really set the stage for these new and advanced models. The first one on the left, making care primary, is going to be launched in this coming summer. This is one mechanism of moving towards primary care support, especially focusing on health equity, as is certainly the federal government has made that very clear, that we need to create access to care and sustainable care in communities that have been underserved. The next model that the feds have announced, and that also will be starting in a staged format over the next year or 2 years, is the HEAD model. And the interesting part about this model in context of our conversation today is that there is a very explicit requirement that there be a plan in place and moving towards legislation or regulation that would support increasing primary care support on the part of that state. So the primary care investment is expected and required. And that's a big statement to make. It's a big lift for any state to be working on that, as you'll be hearing from our other panelists. But I think it was an incredible opportunity and frankly, really applaud that development and the foresight of the Innovation Center moving that forward. The most recent model that was announced just last week or the week before, it's a little dizzying that these have really come in such rapid succession, but also very exciting, is the accountable care organization primary care flex primary care model. This is an interesting opportunity to move primary care support in and really accelerate it and to try to bring things to scale more quickly. So using the construct of the accountable care organizations, the practices as joined together themselves, not necessarily dependent on a state having to say that they will be participating in a specific model. So there's all kinds of opportunities in these, and there's no question that this is a very tangible acknowledgement of the importance of primary care in the context of our system. Next slide, please. So what you'll be hearing about today are from 3 states that have been deeply involved in our primary care development, primary care investment network. This has been, as Jordan said, in collaboration with us at the Milbank Memorial Fund and with generous support from the Commonwealth Fund. And as you can see, we have an opportunity here to share what we've learned thus far and to really put our heads together to strategize on how to make things work better in the future. So this network, I don't need to read the slide to you, but clearly what our point is to have a shared learning environment, develop leadership capacity, and really try to increase the conversations and frankly, the effectiveness of the advocacy working to improve primary care investment at the state level. Next slide, please. This is a very high level overview of sort of our history, and which is really quite recent. We had an exploratory roundtable meeting in December of 2022, and really we're kind of just testing the waters at that point to see if there was significant interest in having a network that we're going to be showing you information about today. We were very excited to really feel very quickly that this was something that for which there was quite an appetite. And really, again, I'm very grateful for the support of the Commonwealth Fund and the incredible work of the PCDC staff in making this a reality. So shortly after that exploratory roundtable, the network was launched in April of 2023. There were 23 states and approximately 50 participants at the initial onset of the network. We've had, I think, 5 virtual meetings and multiple focus work group sessions that are topically oriented. And you can see we'll be talking about some of the aspects that we've been learning about together, such as messaging, trying to create definitions, trying to wrestle spending measurement mechanisms into accountability, et cetera. And in this past a couple of months ago in January, we were finally able to have an in-person event, which was really just a wonderful experience to be able to meet people face to face instead of our virtual sort of habitual way of communicating. This meeting really focused on creating and sustaining coalitions across states as well as internally within states, trying to learn more about measurement and accountability. And there was a great deal of emphasis on messaging and communications with a multi-day workshop that we were able to enjoy together. There's a lot more information that could be shared about the network if you are interested, and we're certainly happy to make those connections for you. But what I'd like to do now is turn this over to our colleagues on our panel, and I'm really looking forward to the discussion.
Thank you so much, Lisa. I really appreciate that overview. I think the federal programs are complex and interrelated, so it's nice to have someone put it all in one place and explain it to us. I'm going to turn it over now to Betsy Boyd-Flynn from Oregon, but before I did, I just wanted to pop in and say there's no chat function, so I can't post people's bios in it. What I'm going to do is figure out a way to put them in the Q&A. So with that, Betsy, thank you so much.
Sure, glad to be here. Can everybody hear me okay? Great. So I'm so glad to be with you today. As was noted, I'm the executive director of the Academy of Family Physicians, and I've been in this role since 2018. But Oregon's work on transforming primary care and centering primary care in our healthcare system significantly predates my role here. However, I've been in and around healthcare stuff in Oregon since 2006, so I had at least a spectator seat to most of what I'm going to talk about today. Without giving you a blow-by-blow bill numbers and so on timeline of how we got to where we are, I'll just say that the Oregon experience, we went first in a lot of ways and serve as an example to a lot of other states. And sometimes it's a cautionary tale. Maybe we can talk a little bit about understanding where we are now and how we understand better, having watched other states come after us in the work towards investing in primary care, and how that's informing my understanding, my organization's understanding, and our coalition's understanding of how we need to push forward from here. So the first thing that we did was begin a transformation of our Medicaid delivery system, that was facilitated back in 2009. We actually predated Obamacare in terms of wanting to dramatically expand access to health insurance for Oregonians increased the number of Oregonians who were eligible for the state Medicaid plan, which some of you may know, an innovator back in the 90s when we first actually had a prioritized list of treatments and began literally rationing care, which sounds draconian, but had the effect of being able to guarantee a basic level of care to more individuals, and really put a critical eye on when innovation in healthcare was appropriate to bring into the system and when more evidence was needed. So that process continues. It's important to note that the state began with the intention of transforming how we delivered Medicaid and transforming how the state as a purchaser of healthcare could drive change. The expectation was always that we would start with Medicaid and then the employee and educators benefit boards from the state, still as purchasers, would follow along and begin to model their insurance offerings and what they demanded from their private insurance companies to follow along with what had been established in Medicaid. And that eventually, having demonstrated how awesome all of this change was, all of the other commercial carriers in the state of Oregon would follow suit. We have not seen much of that. And I'll talk a little bit about that, but it's important to note that Oregon's insurance landscape is really complicated and fractured. We have a lot of insurers here, and we have some pretty hefty ERISA provided plans for our biggest employers, and that has limited how far we can go in truly transforming the system, and in some respects made it more complicated for primary care to function, for primary care clinics to function, given that some of their contracts operate in a very specific and aligned way, and others are really fractured, and you can't legally provide different levels of care. So that complexity has added to some of the administrative burden that, when I think about my members, I think about. So all that said, one of the first things that came after the passage of Health Bill 2009 was the creation of the Patient-Centered Primary Care Home Program. You may know about efforts to create this model of a primary care home. We did not follow the national model. We did it our Oregon way, as we often do. And that program has existed ever since. Clinics can be recognized at one of 5 levels in terms of how they're achieving all of the benchmarks, and the metrics for the PCPCH program are re-examined periodically, and primary care is right at the table for that. And as much as possible, that innovation has followed along with the rest of the payment model innovation. And as much as possible is not complete. So that's okay. Nothing's perfect in this world. I will say that as you may know, in 2015, legislation was passed. It was sponsored by my organization before I came on board to require to create the Primary Care Payment Reform Collaborative, the first of its kind in the country, and many other states have modeled after that, which really brought together stakeholders from across the healthcare space, insurers, patient groups, provider groups, clinics, and really set at the table. The mission of that group is to increase investment in primary care. And the work that they've undertaken includes things like creating a shared model, a consensus model for patient attribution, creating consensus models for value-based payment methodology, doing some of the nitty-gritty work on the really wonky stuff that needs to be in place before you can implement a change like this. And what is amazing is that this group achieved consensus on so many things. And what frankly is disappointing is that so little of it has actually been implemented, because what the collaborative did not have was statutory authority to require any of this. So all of our innovation has been voluntary and has assumed goodwill, and that the benefits of moving towards this would be self-evident. And there is strong data to show that that's true, and the market is hard to move. So we had an evaluation in 2016 that first looked at the first few years of performance for primary care, patient-centered primary care homes, and found savings on the rate of something like $13. $1 invested in advanced primary care yielded something like $13 of savings down the line. And that's been quoted a lot. And that study was followed up more recently with a study published in 2023, and yep, still true. And yet we still have many insurers in the state that do not support the advanced primary care model with the kinds of infrastructure payments and contracting models that allow clinics to really implement that kind of work across the patient population. So, okay, in 2016, we had this evaluation that said, okay, PCPCH is a good thing. In 2017, we followed up the legislation of that created the collaborative with a bill that said, okay, this is the benchmark based on everything we know, based on the STAR report, and based on all the data that we have. Insurers should be spending about 12% of their total medical spend on primary care. And based on our first report, that we weren't even close. So since our legislation to require the measurement of primary care was implemented, there have been 6 reports released. The last 2 are statistically comparable. The first 4, because of methodological changes and data supplier changes, have offered really good information, but with the state has been clear about the complexity of comparing those results in a longitudinal way. I mentioned that because that's a really important lesson learned. As the methodology changed or as the data supplier changed, there were no resources to rerun the prior year reports to get that real sense of like, okay, now knowing what we know, how are we really moving the dial? And given that our most recent reports are from the middle of they're based on claims data, which is 18 to 24 months old. We're right in the middle of the pandemic, and it looks like primary care investment is actually going down in the last 2 reports rather than increasing. Hard to say what the causality for that is, and we'll see where we are as we continue. But the intent of that legislation was by claims data for 2023, everyone would be at 12%. And our claims data from 2020 and 2021, I think that's our newest data, is actually showing a decline. So what will that mean? There is no mechanism in the legislation to assess penalties to the carriers for not hitting that goal. And so all of that, I feel like I sound like Eeyore. I do not mean to sound like Eeyore. This is incredibly important and inspiring work, and I'm so glad that I get to focus on this in my job. And we also, I think, need a revival. In Oregon, we are at a stage where we really need to find a way to pull together the people who are concerned about these issues, who understand the value of primary care, and figure out how to re-inject that energy into the conversation as it stands now. I will say in Oregon, most of you probably watch the national news and see terrible stories about the state of homelessness and substance use disorder in Oregon, and that was the overwhelming focus of our most recent legislative session, which just wrapped a few weeks ago. Lots of funding dedicated to implementing new housing programs and expanding our capacity to provide behavioral health care. There is a tremendous mismatch between the need for people who can care for people with substance use disorder and the number of bodies and educated people to do it. And importantly to me, I do not see evidence that the state is really thinking of the primary care workforce, which already delivers quite a bit of the behavioral health care across the country and certainly in Oregon, as an asset in that fight and as a area to shore up. So that's the kind of stuff the flag that I'm waving these days. I will say too that the state has shifted its focus away from the collaborative. It shifted the FTE that it's able to dedicate to the primary care payment reform collaborative. And so it really is all the members of the collaborative now to figure out how we're going to continue this momentum. The state is able to convene meetings, but not to support work groups or interim work. And so we're going to have to figure out how to proceed from here. And why is that? That's for lots of reasons. And many of your states, I think, will be having some shared experience in that our health authority took a beating during COVID, and there was a tremendous loss of personnel in the department or in the agency, and they're rebuilding. We have a new director who just came on board this year, and we'll see where her goals are. But meanwhile, in 2021, the health authority, in the midst of COVID, released its intention, released sort of a new framework for how it's approaching all of the work that it does with the goal of eliminating health inequities by 2030. And so in as much as advocates may not think that primary care is a lever to achieve equity, that primary care is no longer a focus. Others may quibble with that, and I'd be thrilled to have a conversation with them about it. Having said that, I think to sort of shorthand it, if we can't show how primary care is helpful in the fight against substance use disorder, is a stabilizing force for folks who need stabilizing elements in their lives, who need access to housing, who need support in addressing social drivers of health and the way that those are impacting their daily lives, we're not going to get any attention. And that sounds self-serving. And you all don't know me well enough to know that we need to take care of people in the way that they need to be taken care of. And I don't want to denigrate anyone's focus on everybody trying to do their best, is what I'm trying to say. However, I think there are opportunities for the state to be thinking about and looking at primary care as a resource and putting dollars there. And so that's where we are today. I'm hopeful that will unfold some topics of conversation for the other states, but that's what I have to share with you today.
Great. Well, thank you, Betsy. I want to turn it over to Hanna Nagy from Connecticut.
Great. Thank you, Corinne. Good afternoon, everyone. It's so great to see all of you who are interested in increasing primary care investment in your states. Today, I'll be talking about Connecticut's Primary Care Spend Initiative, which is led by our Office of Health Strategy, or OHS. And OHS's goal is to focus efforts to implement comprehensive data-driven strategies that promote equal access to high-quality healthcare, control costs, and ensure better health for the people of Connecticut. Next slide. Great, thank you. For some background, in Connecticut, healthcare costs are among the highest in the country. Connecticut spends more on healthcare than almost any other state. And annual healthcare cost growth consistently outpaced the growth in the Connecticut economy and household median income. So to counter these efforts, in January of 2020, our Governor Lamont, signed Executive Order Number 5. This was created to improve healthcare system performance in Connecticut by making healthcare more affordable, providing quality care, prioritizing health equity, and improving population health, as well as to support the state's primary care system. This effort is collectively known as the Healthcare Benchmarks Initiative. Next slide, please. So the Connecticut Primary Care Spending Target is one component of the Healthcare Benchmarks Initiative. The initiative consists of the spending target, the cost growth benchmark, our data use strategy, and quality benchmarks. While each of these initiatives were created to address specific components of Connecticut's healthcare landscape, they work collaboratively to improve access, quality, and affordability for Connecticut residents. Specifically, the cost growth benchmark established the expectation that healthcare spending should grow at a reasonable rate tied to the rate of state economy and income growth. The data use strategy is a complementary strategy that leverages our state's all-payer claims database, as well as other sources to analyze cost and cost growth drivers. And the quality benchmarks are quality measures to which OHS has attached target values, and that all private and public payers, providers in the state must work to achieve to improve healthcare quality. We will be discussing the primary care spending target in depth in the following slides, but just know that all 4 of these initiatives work together in order to improve healthcare quality in Connecticut. So during the 2022 legislative session, Executive Order Number 5 from January of 2020 was codified under Public Act 22-118, sections 217 to 223. This established the requirements for OHS to collect and report on data from the payers for the cost growth benchmark, the primary care spending target, and our quality benchmark initiatives. Next slide. Okay, great, thank you. So a primary care spending target is an expectation for which percentage of healthcare spending should be devoted to primary care. It aims to incentivize insurers and provider entities when investing resources to prioritize and support primary care. We believe very strongly that high-quality primary care should be accessible to all the residents of Connecticut in every community, and that strengthening primary care is a high priority. Next slide. So in order to rebalance and strengthen Connecticut's healthcare system through supporting improved primary care delivery, the primary care spending target was set with a goal of achieving 10% of total healthcare expenditure by 2025, and that was established with the executive order and then through codification. During that time, there was a lot of discussion with some of our advisory bodies, particularly our primary care advisory body, which consisted of patients, clinicians, and other experts in the field regarding the values. So our 2021 target value was set based on the best estimate we had at the time for baseline spending. And then ultimately, as we received 2019 data, we set the 2022 calendar year target at 5.3%, which was the baseline that was actually calculated from the data. And then we determined to make near equal increases of about 1.6 percentage points in the years following to get to the 10% by 2025. OHS annually reports performance relative to the benchmark at the state, the health insurance market, so Medicare, Medicaid, commercial, and insurer levels. You'll note that for this calendar year, 2024, the primary care spending target is at 8.5%. Next slide, please. When establishing the primary care spending target, one of the largest challenges that we faced was creating a primary care spending definition to measure against the benchmark. OHS utilized several advisory bodies to determine a definition of what constituted primary care spending. It was decided that the definition of primary care spending would build upon a methodology established in collaboration with other New England states. So for the purpose of assessing performance against the target, in Connecticut, we include both claims-based payments using a procedural code level list. You'll see some examples on the slide. And non-claims-based payments such as infrastructure investments and value-based payments. Next slide, please. So we also had to determine what constituted a primary care provider under our spending definition. In Connecticut, we determined that doctors of medicine and doctors of osteopathic medicine, when practicing family medicine, pediatric or adolescent medicine, and internal and geriatric medicine, when practicing primary care. We also determined nurse practitioners and physician assistants when practicing primary care would be included in the definition. There was a lot of discussion regarding whether OBGYN providers providing primary care services should be included in the spending definition. And ultimately, the advisory body recommended that OHS separately calculate and monitor spending associated with primary care services provided by obstetric gynecology providers and midwives. Okay, next slide, please. Well, Connecticut does have an all-payer claims database, which I noted earlier. OHS primarily utilizes data submitted by the payers to assess performance against the target. This data is collected as part of our cost growth benchmark data submission. So we collect all the data for cost growth, primary care, and quality at the same time from the payers. We collect data from several sources, including but not limited to commercial and Medicare Advantage data from the insurance carriers when applicable, Medicare fee for service as reported by CMS, and then Medicaid data as reported by our Department of Social Services. To assess primary care spending at the state, market, and payer levels, OHS calculates primary care spending as a per member per month, PMPM, as a percentage of total medical expenses. So TME, PMPM. And this is assessed as a percentage of TME, noting we exclude long-term care in our analysis. Last slide, please. So in 2022, statewide primary care spending accounted for 4.9% of all medical spending. Even though we did not achieve the state's primary care spending target of 5.3%, we are making progress toward increasing primary care investment in the state. So in 2022, statewide primary care spending reached 1.05 billion, up from approximately 1 billion in 2021. And the primary care PMPM went up $1 from $29 to $30. So going forward, we're hopeful that that trend will continue and increase primary care in the state. At this time, I'd be happy to answer any questions. Thank you.
Thank you so much, Hannah. I think we'll hold questions till the end, but keep adding them to the chat. I've seen several come in and we'll have time for those. But first, I want to turn it over to Louise Cohen to hear about New York.
Great, thank you so much. It's really lovely to be here with all of you and both the participants on the panel as well as the folks who are listening in. And I think we all have a lot to learn from each other. So get the first slide up, if you will, Jenny. Move the next slide. Thanks. So PCDC is a little bit of a different kind of organization than many of the rest of you. We are a not-for-profit community development financing institution. We've been around since 1993. We were created as a public-private partnership, originally by the city of New York, to try to figure out how to increase access points for primary care, particularly in Black and communities of color in New York City, as a matter of health equity. Our mayor at the time, David Dinkins, our first Black mayor in New York City, declared that health care was a human right and really was very concerned about the access points. So PCDC was started as a capital financing institution, essentially to support new access points in those communities, which we have done over the last 30 years, have invested across the country over $1.5 billion into new primary care access points, provided consulting on a variety of primary care issues and also primary care advocacy. Next slide. So these are just some of the ways in which we promote primary care in a very broad sense. So we are not a government agency, so we're not responsible for the technical work that I think that my colleagues here in Oregon and Connecticut have to do. We're really about promoting access to high quality, affordable, accessible primary care particularly in communities that have been disinvested historically for a whole variety of reasons. Next slide. So one of the things that I think happens a lot as we sort of talk about this issue in New York, as people always ask me, well, what's the money going to go for? You guys just want to pay doctors more money, and why should we do that? And my answer is always, yes, actually, we do want to pay primary care doctors more. They're at the almost bottom of the list when you look at their salaries for any other part of the medical profession, except for public health doctors, who are one step below primary care doctors. So yes, we want to do that, but that's not the only thing. What we want to do is think about, how do we pay for care delivery in a very different way? How do we think about higher reimbursement that supports an entire care team, not only a physician, even a nurse practitioner, a PA, but really thinking about the whole care team, which includes medical assistants and front desk people and psychologists, behavioral health people, all the folks that we know kind of need to come together to promote a robust primary care approach. So we believe that investing in both the physical infrastructure of primary care as well as the sort of human capital side of primary care is really quite important. And when we talk to lawmakers and others, we always use this framework because I think it's important to help people understand, what does it mean when we say we want to invest more in primary care? Where does that money go? What's it actually being used for? Next slide. So I think every state is somewhat, idiosyncratic. The context of the state is really important. You have to know who the key players are, who the decision makers are, who are the people who are going to implement this. So PCDC began prioritizing investment in primary care as sort of a key advocacy issue, because we think that it's actually essential to bringing the healthcare system to really become more primary care centric. And so we started looked first at Rhode Island and at Oregon. Thank you, we appreciate Oregon. And we thought you all were great leaders in this, right? You were sort of pushing this envelope before other folks had really jumped onto this, what I think is now kind of a movement that's really been developed. And so we actually brought together the executive branch in New York State. It was the agencies, the health department, which regulates and is a payer of Medicaid, the Department of Financial Services, which regulates commercial plans, the Office of the Governor, and the office, the budget office in New York State. And we brought everyone together, actually over a couple of meetings, and we said, listen, we think that this will really make a difference both in addressing the total cost of care in New York State, as well as improving health status, as well as creating a system that really will promote the health and well-being of people who are living in New York State. And they all said, this is fantastic. We really like this idea. I think that's great. And they were willing to meet with us as many times as we were willing to meet with them. But what became clear over time is that they weren't quite ready to move forward as a state through some kind of executive action. And so one of the things that I would say in this period is PCDC wasn't at that time bringing with us a lot of stakeholders. We were really going to the state as PCDC people that we'd known them for a very long time. They knew us. We had a lot of business in common, worked with them very closely. But we did not necessarily say, look, there's a lot of other people out here in the state who actually really care about this thing as well. And we'd really like you to listen to us as a collective, as a collaborative. And then, ultimately the pandemic intervened. And we did have some conversations with particularly with the health department, who was thinking about, some of these issues, but really the pandemic sort of just became the overwhelming issue that I think everybody was dealing with. I think the other thing is that, New York has a all-payer database, but it is not public. It's not publicly accessible. The other data that would include a number of other ways in which we could get at a variety of things that would help us push this issue forward are really not public databases. So I think finally, it was also clear over turnover in government that while everyone agreed that primary care was important, really the state in the last, I'd say, 8 to 10 years has not put forward a vision of what they want the overarching healthcare system to look like. So I think those are some of the particularities around New York State. So next slide. So when our executive branch didn't move forward with sort of what we had hoped would be kind of action on their part, and certainly based on the interest of the people we were talking to, we decided to think about the legislative route. So we talked with the leaders in each house in New York State and the Senate and the Assembly, the chairs of the health committees, and essentially we worked with them to motivate them to raise this issue as a legislative matter. And so they agreed, and with our support and help and a lot of back and forth, they ended up introducing a bill that would create a primary care commission, which was essentially a stakeholder task force that would study primary care spending in the state and that would make recommendations based on New York State data to increase spending. So all that voluntary, non-regulatory approach. And the bill passed in both houses, went to the governor's desk, and it looked like it was going to pass. And interestingly enough, the state agencies that I mentioned earlier all started working on a plan together to actually implement this, which was great. So we were very excited about it. But then the governor in the last minute vetoed the bill. And she vetoed it because she believed that commissions are unfunded mandates. And so there was no money in the budget for it, and she was concerned about it. She vetoed it with a number of other commissions. But I think the underlying question was New York State is a very hospital-centric state. And I think, frankly, the current administration is really thinking a lot about hospitals and trying to make sure that hospital care is available to everyone in the state and doesn't necessarily see primary care in quite the same way. So having had that experience, next slide, we decided to take a different tact, which is to not go the commission route, but really to say, look, it's actually really important that we think about increasing spending. So let's just go to increasing spending. And we worked with, again, legislative leaders, sort of one was different, but they're both the health committee chairs in the Senate and the Assembly respectively, to introduce a spending target bill. And we're actively lobbying on that bill. And you can see here in the slide, it basically requires all payers, obviously not the ERISA plans, but all payers to report their spending on primary care as a percentage of their total spending and to publish that data. And it requires ultimately a 12.5% target and with the idea that they would increase spending 1% year over year to get to that target. So you might ask, 12.5% seems like an odd number. And it is a slightly odd number, but I think we had some legislative champions who basically said, we want to be, we want to do this so that we're really above everyone else's spending targets. We're New York, we're the biggest, we're best. And so we compromised on 12.5. I think as our team has really looked at this data, we don't think there's data that says 12%, 13%, 15% is the best. It's hard to figure out what those numbers mean. And one of the reasons why I think we do need some national work on this, which maybe we'll talk about later, but I do think that that each state right now is kind of doing something in the ballpark of 10 to 12, 13%, something like that. Next slide. So we so we're now in the process of actively lobbying, trying to move this forward, but we're also trying to bring with us this time a much broader group of stakeholders who are very concerned about primary care and also interested from a variety of different viewpoints in moving this issue forward. And interestingly enough, we have heard in the state, as I think we've heard nationally, many more people kind of echoing our language about primary care spending than had before. So it's beginning to create somewhat of momentum. I don't know that we're all there yet. I don't know that this bill will pass. We will wait first for our budget to pass in New York State, and then we'll hopefully get some momentum on this particular item. So let's see, next slide, please. I also think that I want to point out that in New York State, there's some other things that we think go along with the concept of primary care spending. And for us as a community financing institution, we really believe that we need to make sure that there's sufficient capital to improve access points for primary care throughout New York State and actually really around the country. So there's been a huge investment from New York State into what's called a healthcare transformation fund. Most of it historically has gone to hospitals around the state, many billions of dollars. And we have advocated for a long time for a set aside for primary care so that there would be sufficient capital to really create physical plant, working capital and other things that we know are needed for primary care practices to actually get to the point where they're truly providing the kind of care that we think is important, whether it is hiring new team members, reconfiguring their space so that they have collaborative spaces to work together, really thinking about building spaces that are based on the principles of trauma-informed care, any number of things. And we really think that there's, at the state level, really should be an earmark for primary care that is substantial, and at least 12.5% of the capital going out. This has not happened to date. Historically, there have been some sort of small pots of money set aside for primary care, but certainly nothing at the level that we think is important. And then finally, next slide, the last slide is just to say that there's some other New York State things that are happening. The governor's office has put together a Future of New York State Health Commission, which is an attempt to try to say we're not starting with a vision of what the healthcare system would look like, but we just want to look at the data and see where that takes us. In the first year, they're going to focus on hospitals and long-term care, two very difficult and sort of they're big conundrums with a lot of funding needs. And so we're hopeful that at some point in the future, they will take up the issue of primary care. It won't be this next year. And then there, as Lisa pointed out earlier, there's all of these sort of federal Medicare programs that are kind of swirling around that have some important impact in trying to think about how primary care works. And finally, I guess I would say that New York State's 1115 waiver, which was just approved, is actually not a primary care focused waiver like some of the other states. It's a waiver that's primarily focused on social needs, health-related social needs, and training workforce, but really not so much primary care. So we're still in process. We're very excited about the prospect of moving forward with our bill, but we really appreciate the work that folks like Connecticut and Oregon have done to help us understand what some of the concerns and challenges are. So thank you very much.
Great. Thank you so much, Louise. So much great progress across your states in this work to increase investment in primary care, but clearly also some challenges. I want to start by asking, we've gotten a few questions in the chat about how increased investment can actually translate to better care on the ground. So I'd love to hear from you all how states can think about this issue and ensure that increased investments are supporting things like workforce recruitment, retention, team-based care, comprehensiveness of care.
Who wants to go first?
Well, I can only speak aspirationally because we haven't done it, but I'd love to hear how you all have done it in your states so far and to give us some hints about how we can make sure that we can do this in New York.
I would say that experience varies across clinical types, in that when I talk to some of my leaders in my organization who work at FQHCs, they're doing amazing things. Clinics that primarily serve Medicaid populations have the payment model from their Medicaid, their MCO, to do things like support care coordination, support home visits, support things like group visits, or having a food bank in their clinic, or incorporating dental care into their clinic. And that is amazing innovation that is super useful to you and instructive, and also difficult to replicate in a clinic that cares for primarily privately insured individuals, because the private insurance companies have not followed suit with those payment models. And I could go on and on about all the issues around the marketplace. I'll just sum it up by saying the billboard near my house during open enrollment season was for a insurance plan that is affiliated with the health system, and its biggest selling point was that you do not need to coordinate your care. You can see any specialist you want with no referral, which I understand the value of that. And I also, to me, it's emblematic that as a populace, and this is no one's fault, we have not yet shared the value that this kind of care coordination and team-based care can really offer to everybody, and not just those with the highest needs. So that's a piece. And then I would just say, in terms of workforce development, we have anecdotal stories of people who start out working at a front desk and end up going to nursing school or medical school. And because of the investment some of these plans make possible in continuing education, in expanding the roles of people who are already in clinical settings. And this is critically important in rural areas where it's difficult to recruit people from outside the rural area to do the work, but growing them at home is much easier. Those are the kinds of things that this work has opened up. And it's very exciting. And I think that if we can achieve all the things that we're trying to achieve with our, one of the other focuses of the OHA right now is the adoption of value-based payment models. There's a tremendous amount of promise if those plans, those models can be implemented to simplify the administration of healthcare and potentially redirect the dollars to where it needs to go, where we're providing for people and less.
Great. I know we only have a few minutes. One question I definitely want to get to, which Wayne Altman put in the chat, is really, if you could go back in time, what would you have done differently? Or for you, Louise, For states that are earlier in this work, what's a lesson that seems to be emerging that you would recommend for them to consider?
I think that, I'll just know, but I think that the thing that states should think about is don't just think one route, right? Think there's at least 3 different routes to get to this issue, including, public education. But I think, there's a legislative route and an executive branch route and a regulatory route. And I think, we may have sort of really tried to push the executive route as far as we could take it. But I do think that sort of go for all of those things, and I think be persistent. I do think that Bob Ronner put something in the chat that I think is really important, which is we did not and have not yet really been able to figure out how to crack the employer question, really to bring employers with us, big business. I think that's essential because we know that state governments are responsive to employers, and they have a big stake in health insurance. And so, and obviously the health of the communities that they work in. So I think that's a critically important thing to do. And I do think that the purchasers group on health has been very active in this regard, and we really appreciate that. But I think we also need to think about how to do that in our states. We have not yet cracked that nut. I'd love to hear thoughts about how to do that better.
Yeah, so echoing what Louise said in the beginning, Connecticut was a state that started under executive order and that moved on to legislation. I will say starting with executive order definitely helped us because it allowed us to be flexible, considering options for data collection and feasibility before it was codified. The thing to note is because we started under executive order, submission of the data was a voluntary effort. So there was not an incentive or disincentive for the payers or provider entities to participate. We started in a very collaborative environment, and that's the kind of something that we've continued to foster throughout this process, even as we've gone through legislation. I will say that while we started with executive order, I don't think that you can rely on it for long-term sustainability of the program. Because ultimately the legislature is the one that can require data submitted to the state. And so I'll say when considering what is best for your state, and Louise, you kind of went into a little bit of this as well, is determining the culture of the payers in the state, kind of what your relationship is with them. Are they local or regional plans? Are they national plans? Do you have a history of working together? Just considering those types of options before going with any one approach.
And Betsy, 1 minute, do you want to chime in on?
1 minute. I would just say really fully understanding what levers you have at your disposal. And it sort of ties up what we were just talking about. Are your employers aligned and strong and ready to change? Is your insurance commissioner appropriately backed by statute that will allow it to go in and make things move? Do you have support in the legislature? Do you have support from the community base? That was one of the questions we thought we might talk about. It's very difficult to get community to understand this piece. And employers, we haven't cracked that nut in Oregon either. And the last piece I'd say is just build relationships as deep as you can across all of those organizations, because staff turnover impacts the ability for stuff to continue. Oregon's been really lucky that our team in the Transformation Center at OHA has been consistent, but folks at the other stakeholders have been moving in and out.
Great, thank you all so much. I'm going to turn it over to Jordan to close this out.
Thank you all. Thank you, Corinne, for moderating this great panel. It's been really interesting to hear all of these different perspectives all at once. I think it gives a really interesting overview of the way that people are going about this and the challenges that they continue to face. I know for me, hearing from Betsy is always like both inspiring and also a little bit unnerving when you think about the state that's the furthest along is like not quite getting there. But I really appreciated it. And I just wanted to say for those of you who are listening and who are not part of the Primary Care Investment Network, but are part of a state effort to try to do something like that, feel free to reach out to us. And we're really grateful for your time. And with that, I will close out. Thank you so much and have a great rest of your day.